Good afternoon and welcome. My name is Sarah Norman. I'm Director of Healthy Homes and Communities here at NeighborWorks America. Welcome to the first webinar in a two-part series on healthcare financing. We hope that through this two-part series we can address the important questions related to healthcare financing and highlight practices to further integrate health and into housing and community development. Before we start, we wanted to do a few webinar logistics. First, we've muted all lines. You can submit your questions as you go using the Q&A button at the top of the webinar window. And if you're having any trouble with the Q&A button, you can also email questions to health@nw.org, health@nw.org. The webinar will be recorded and posted on the NeighborWorks YouTube channel. The links to the recording and the presentation slides will be sent out in a few days, and they'll include resources to dig deeper into the subject. If you have any technical difficulties at all, please email health@nw.org. Today's webinar, Healthcare Financing 101, will be 1 hour in length, and it features Lynn Quincy, Director at the Healthcare Value Hub at Consumers Union, a division of Consumer Reports. Before we turn the presentation over to Lynn, I want to give you a little bit about a background on NeighborWorks America and the Healthy Homes and Communities Initiative. I know many of you know NeighborWorks America, but just in case, NeighborWorks America is a national nonprofit established by Congress in 1978. It was created to build strong, resilient communities, and every day today, more than 240 organizations in the NeighborWorks network help families find safe, healthy, and affordable housing, whether they own or rent. And NeighborWorks America strengthens communities and empowers individuals by supporting the efforts of its member organizations and the community development field through grants, training, and technical assistance. We support and engage residents across the lifespan. And in the last fiscal year, we helped to create, or the NeighborWorks Network helped to create 21,000 new homeowners. The NeighborWorks Network owned or managed 154,000 rental homes, 53,000 jobs, 55,600 homes, and 360,000 families with affordable housing. So there will be a quiz on this at the end of this. No. Just a few seconds about the Healthy Homes and Communities Initiative. Having folks here at NeighborWorks think about health is really important because it shows the importance of housing and community development to health outcomes. And we've been doing a lot of work to support NeighborWorks network organizations and the housing and community development field writ large to integrate health into the way community development is done. A partnership with the Robert Wood Johnson Foundation and the County Health Ranking and Roadmap Program has been really integral to changing how we do work. We have a lot of work going on to sort of understand and document health outcomes, including a collaboration with Success Measures, where 20 organizations are documenting health outcomes. We also have 28 demonstration sites throughout the NeighborWorks network, supported by 3 types of NeighborWorks grants that are looking to see how they can influence health outcomes. Now, I am going to turn this over to Lynn Quincy, who's going to guide us through Healthcare Financing 101.
Well, good afternoon, everyone, unless you're on the West Coast, in which case it's still morning. I wish I could meet you in person because I'm so impressed that you're willing to learn about healthcare financing as part of getting to better housing for people. So kudos to everyone listening today, and I look forward to your questions. If you could advance the slide. I was asked to reiterate the goals for today's webinar, which have 2 parts. The overriding goal is to provide you with some basic knowledge and familiarity with healthcare financing. How does it work? What is the vocabulary that's used? With the idea of teeing things up for webinar number 2, which is going to go much deeper into partnership opportunities created by new flexible funding and the integration of health and housing. We are going to introduce it just a tiny bit today, but the bulk of that conversation is in webinar or seminar number 2. Next. So I work for Consumer Reports. Consumer Reports is an 80-year-old nonprofit mission-driven organization, and their mission is to keep consumers safe in the marketplace. And as part of their mission, they have what we call the policy and advocacy arm, and that's where I work. And because we can't only test products, we actually have to be in the regulatory and legislative arenas as well. And I work in that arm exclusively on health policy. Next. So what we're discussing today is the answer to this question, who pays for healthcare? And unfortunately, in the case of the U.S. healthcare system, the answer is it's complicated. Next. We have a lot, well, first of all, as you may already know, we spend a ton of money on healthcare in this country. It's about 18% of our economy is healthcare spending. And we have a lot of different payers, which I'm going to be introducing you to today. Just FYI, the largest source of payments comes from our private health insurance system, but there are many other payers, and you're going to understand them all by the time we get to the end. But first, let's back up for a second. Why do we need payers? We don't have special financing arrangements for things like TVs, which can be fairly expensive. We need, this is a set of services where a few people, that's the left-hand side of the chart that you're looking at, have very low health expenses. And let me start that one again. This is healthcare is a situation where the majority of people have very low health expenses in any one year, and a small number of people have extremely high healthcare expenses in any one year. And under these situations, most families cannot sustain a large health shock. Just for example, a year's worth of treatment for breast cancer could cost you $100,000. So that naturally lends itself to insurance, where everybody contributes to insurance premiums, and that helps cover the extraordinary costs that a few people are realizing. If you would click once, for the group that I have that this data is derived from, that little red bar actually represents about $5,000. That's how much this group of very high spenders and a lot of very low spenders, that's how much they spend on average. If we have everybody contribute $5,000, we can cover that big spectrum of health spending. So that's the basic idea of health insurance, but that means there are these entities called payers involved, which we're going to be talking more about. Next slide. But sorry, Lynn has. So let's talk about, I thought we would start from the largest source of coverage to the smallest. And with that, I'd actually like to ask you to go out to our first poll. This is where you get to interact with me and show me how smart you are about healthcare spending. So this question asks, what does World War II have to do with, and the poll is open, I believe you can click on it right now. What does World War II have to do with the health coverage we get from our employers? Perhaps it has nothing to do with it. Perhaps it has something to do with the special treatment that veterans get, or I'm asking you, maybe it has to do with medical devices developed during World War II, or maybe something about the wage freezes that happened during World War II. We'll keep the poll open just 10 more seconds, select an answer, and then Hugh will display the results. Okay, if you've had some responses, Hugh, why don't you go ahead and show them what the response is? Ah, well done. I knew you were a smart group. The correct answer is D. We are the only country where our employers are involved in the provision of health coverage. And the reason is that during World War II, there were wage freezes. Employers still wanted to attract employees, so they started offering non-wage benefits, including the provision of health insurance, and it has endured since that time. If you would close the poll and return to the slide and advance to the next slide. So private health insurance coverage covers more people than any other source of coverage, and it's probably very familiar to you. You probably have this type of coverage. Typically, the people enrolled are workers and their dependents, but not all workers. A surprising number of workers, and these may account for clients that you work with, do not actually get an offer of health insurance from their employers. Typically, low-wage employers may not offer health insurance. It's financed through a combination of employee-paid premiums, through employer-paid premiums, through the cost sharing that you pay when you go to the doctor, and you may not realize it actually gets preferential tax treatment. It's a form of compensation that is not taxed. That's called a tax expenditure, And it is actually an enormous part of what, our federal budget is, that tax expenditure associated with not taxing health insurance. It's administered by your employer, typically with a health plan. The employer may bear the risk, or the health plan may bear the risk for large claims that maybe exceed or fall less than the premiums that were collected. And depending on who bears that risk, that will determine whether it's the regulator is a state regulator or perhaps a federal regulator. You can ask more about that in Q&A. Next slide. I touched on, I mentioned cost sharing. I want to be sure that we understand that. Most people are very familiar with premiums, the monthly expense that you face for insurance, whether or not you use services. One click, please. What people are less familiar with, you can click all the way through, is the cost sharing terms and what they mean. So with every health plan, when you use services, you may or may not, depending on where you are in your plan year, face a cost for using services. And this cost sharing can take many forms. It can take the form of a deductible, an amount of money you have to pay up front before the health plan starts kicking in, or it could be that the cost is shared between you and the health plan in the form of a copay or a co-insurance. Or if you've had a lot of healthcare expenses in a year, you may have hit what's called your out-of-pocket maximum, and that means the health plan is starting to pay 100% of the cost of services for the rest of the health plan year. So that's cost sharing. You may have encountered it in your own life, but that's what I'm referring to when I say cost sharing. If you would go to the next slide, please. So as we've already mentioned, employer coverage covers more people. That's our dark blue pie slice there, than any other type of coverage. It was also, from my first slide, the largest source of spending. There is that red slice, if you would click through one more time, represents another form of private coverage, which is when you buy coverage on your own. Yep, you're good. Anybody can buy coverage on their own, although you typically would not buy on your own because you have to bear the entire cost of the premium. You would typically only do this if you did not have another health insurance option. Maybe your employer doesn't offer coverage, maybe you're not eligible for public programs like Medicare and Medicaid, which are still to come in this presentation. Now, this is always regulated at the state level, but there is a caveat here. Under Obamacare, the Affordable Care Act, if your income falls below a certain level, you can actually get a subsidy to help you pay for health insurance. These subsidies actually take two forms. One is a tax credit subsidy to help you pay your health insurance premium, and that goes pretty far up the income stream, which I'm going to demonstrate in a moment. The other type of subsidy is for much lower income families, and it helps them with that cost sharing that I just referred to. So those are some things built into Obamacare with the Affordable Care Act, which is the law of the land for now. And the reason that's there is that most families actually would struggle to afford private health insurance if they didn't get a subsidy. And if you have questions, we can go into that in Affordable Care Act. Next slide, please. We also have what's called public forms of coverage, where there is a state or federal government role in the administration and financing of the coverage. Medicaid is one such example. This is a coverage program for very low-income families. It always covers children. In most states, you can get coverage for, and seniors. In most states, parents can get some sort of Medicaid coverage, the disabled populations, and then only in some states can childless adults under 65 get this type of coverage. So there's a lot of variation across the states in exactly who can be covered. It is financed through a combination of state revenues and something called federal match, where our general federal dollars come in to help pay for it. And the way that responsibility is shared actually varies from state to state. But for the enrollee's perspective, it is a good deal in the sense that these are very, very low income families, So they are rarely charged premiums. They're rarely charged any cost sharing. You just go and use services, although you have to use the services of providers who accept Medicaid. Next slide, please. So we've talked a little bit about being low income and qualifying for either the Affordable Care Act subsidies or Medicaid coverage. And in the healthcare world, our concept that we use to measure what is someone's income is called the federal poverty level. One click, please. This is established every year. It creeps up year over year, and it is tied to your family size. So in the current year, if you have a family size of 1, you are considered to be at the federal poverty level if you make about $12,000. But as you can see from this little chart, it goes up by a little more than $4,000 each time you add someone to your family size. And these various programs will talk about multiples of the federal poverty level. If you could click 3 times. So for example, you might, in some states, you might qualify for set types of coverage if you're at 200% of poverty, which is simply twice those amounts in that first federal poverty level column that I showed you, 300% and so on. Now, I picked 400% because that is the income level at which people can get those Obamacare tax credit subsidies that I mentioned to you. Whereas poverty level, the 100% of poverty level, the column right next to family size, roughly you have to be at about that poverty level to get Medicaid in many states. And that's only if you are in one of the primary eligibility categories. If you would click to the next slide, please. This shows a little bit of the variation. So parents, which can typically get better access to Medicaid than non-parents, in Texas and Alabama, where the eligibility thresholds are extremely low, you have to be well below those poverty levels I showed you in order to get Medicaid, 18% of federal poverty level, whereas there's some very generous states out there, Connecticut and the District of Columbia, where you can be well above poverty level and still get Medicaid. And then as you can see, we have some states where if you're not a parent, if you're a childless adult and not a senior and not disabled, you may not be able to get Medicaid coverage at all, no matter how low your income is. Whereas in other states, you can get it, but it might be at a slightly lower income level than is true for parents. So that's a little bit about the world of Medicaid. If you would continue, please. Oh, I think we go out to another polling question, if you would. So Hugh's going to open up a new poll for you. All right, that's our old poll. We'll go to one more. There we go. So the poll is open. If people would respond by clicking on an answer, which of the services listed below are not required coverage under Medicaid? I mentioned that this is a governmental program, so there's a lot of decisions made at the governmental level about what's in, what's out. Click on any of these services that you think perhaps are not included as part of Medicaid coverage. We'll keep it open 10 more seconds. All right, I'm sure you've made your selections. Hugh, if you would close the poll and display the results. All right, so these are excellent guesses, so you'll be surprised to learn that none of those services listed there are required to be covered under the Medicaid benefit. And I'm going to talk about that a little bit because it's going to have bearing on the next seminar. If you would close the poll, Hugh, and just move on to the next slide. Hugh's doing a great job. So Medicaid is a governmental program. It was part of President Johnson's Great Society initiative in 1965. And Medicaid, along with Medicare, which you're going to be hearing about in a moment, were modeled on the type of health insurance coverage that was offered then. And oddly enough, it seems odd today, prescription drugs, there were a lot fewer treatment options that took the form of drugs, and it was not typically a covered benefit. So when they set these coverage programs up, there was a lot of things that weren't required to be covered. But what happened, as I'm sure you've encountered in your own life, it actually would be hard to do a good job of treating many illnesses without access to things like prescription drugs, physical therapy, and a whole host of other things. So what happens is that even though it's technically optional, these things are typically covered at the state level. So we're going to come back to kind of what are covered services towards the end of this program, where we wrap this all back to what does this have to do with housing. The next slide, please. I wanted to briefly mention there is another public coverage program. It's specifically for children, although occasionally states will sneak some parents in there as well. And it was recognized, the Children's Health Insurance Plan was passed in the 90s because it was recognized that there were many, many families out there. They earned too much money to qualify for Medicaid, which, if you'll recall, is for very, very low-income families. But they certainly didn't have an offer of employer coverage, so they were stuck without a health insurance option. So people are a little bit more inclined to cover children than those childless adults, as you're probably detecting. So they put in place the Children's Health Insurance Program. It's set up like Medicaid in many ways. It's shared, the cost of it is shared between states and the feds. It may, if it features cost sharing or premiums, they're very, very modest. But it is specifically for children. It goes farther up the income stream. And because children are the group that has the highest rates of coverage, particularly with passage of the Affordable Care Act, and they have rates of coverage that are 96% of the nation and higher, whereas uninsured rates for adults are much fewer. As a percent of the population, adults have lower coverage rates. The next slide, please. So let's talk about Medicare. Medicare sounds like Medicaid, but it's different. Medicare is for seniors, people who are considered long-term disabled. They can be under 65 under that scenario, or they have end-stage renal disease and a few other categories. Medicare is financed through a combination of things. It's, beneficiaries do pay some premiums unless they're very low income. We all pay Medicare taxes out of our paychecks, and that helps finance the system. And there's also some general federal revenues that go to pay for the coverage that our seniors get. This is not a responsibility that's shared with the state. It is administered by the federal government, specifically the Center for Medicare and Medicaid Services, or CMS. If you would click once. So Medicare, if you think everything was complicated thus far, it's about to get a lot more complicated. Medicare has many parts. When Medicare was passed in 1965, it did not include a drug benefit, and instead it was set up like private health insurance at the time, where there was this hospital benefit, and then there may or may not be a physician or doctor benefit. So in Medicare, the hospital benefit is called Part A, and that has one type of financing. Because it's paid through your Medicare taxes, beneficiaries don't actually pay premiums for Part A, but they do face cost sharing, which can sometimes be pretty high. Part B is associated with a premium that pays for doctor services and a bunch of other things. It also has cost sharing. And then during the George W. Bush administration, they passed something called Part D, which for the first time created a drug benefit. It was a long time coming, and that also can feature premiums and cost sharing. But there's a whole, you'll notice in our sequence of letters here, we're missing a letter. We're missing the letter C. So what's Part C? If you would click once, there is this alternative to what's called traditional Medicare, called Medicare Advantage or Part C. These are private health insurance plans that are offered as an alternative to traditional Medicare in most communities. They're not available. Private health insurance plans like Humana or United Healthcare, they are not required to offer these plans. So in some communities you can't get them, but in, for example, Florida, there is a huge number of Medicare Advantage plans available. That's where Part C went, into Medicare Advantage. In this case, the services are all bundled together. They're often set up as HMOs, health maintenance organizations, which means you have to use the providers in the network. You can't go to out-of-network providers. Whereas Medicare is accepted, traditional Medicare is accepted by almost every provider, something like 97% of providers. So you have the liberty of getting your care almost anywhere you want to take it, as long as they take Medicare. Medicare Advantage may feature premiums, and they almost always feature cost sharing. It just depends on kind of how the program is set up. The cost sharing in traditional Medicare, which has the red circle around it, can sometimes be onerous for seniors to afford. It's a very old benefit design. Your out-of-pocket expenses are not capped. So there's yet another stream of financing for Medicare. If you click to the next slide. These are called Medigap or Medicare supplement plans. These are private plans, but they are standardized in order to keep the consumers trying to navigate among them into these specific sets of covered services. They have letters, A, B, C, D, as you can see. You don't need to read this. The bottom line is people who are eligible for Medicare can opt to buy a private plan that fills in the gaps, that fills in that cost sharing. And as you can see by the shading, these plans do different things in terms of what they fill in. And so this is yet another thing that seniors have to forget the Part D and the Part C, then they also have to decide if they want a Medigap plan to augment the coverage they have. So it's rather complex, and there are some people whose full-time job is to help our seniors navigate all these health insurance options. Having said it's complex, I will remind us that it's a guaranteed benefit, and there are a lot of people who struggle to maintain health insurance coverage, and they're just waiting for the day that they'll become eligible for Medicare. So we've been talking about healthcare financing. I've been sort of talking about nominally how does all this stuff get paid for, but now I'm going to segue into some more policy issues, because this is how we're going to weave in how housing fits in. When you think about who pays for healthcare, if you would click once, it's really the consumer at the end of the day. Click one more time. They're the ones who pay the taxes that finance our public coverage. They're the ones who take lower wages in response for employer-sponsored coverage, et cetera, et cetera. And of great concern to consumer advocates out there, such as myself, is the fact that almost all experts agree we are probably overpaying for health care. We have what's called unwarranted price variation. Actually, you can click to the next slide if you would. We have prices that are considered really too high. They can't be justified. We have inefficient care delivery. It results in waste in the system. And the Institutes of Medicine issued a report several years ago, and they think that up to 30% of what we spend on health care actually may be a form of waste. So that's, given that people struggle to afford health care, given that consumers are always paying the bill at the end of the day, that this is of great concern, and it causes a lot of consumer harm. So we, in my job here at Consumer Reports and at the Healthcare Value Hub, we spend a lot of time thinking about what can we do about this problem? How can we get the waste out of the system? How can we get prices to more fairly reflect the cost to deliver plus a reasonable profit? Today, if you click through to the next slide, we're just going to focus on two of these interventions because it's going to help us with our discussion about housing. So of all the ways that people are examining to get to better healthcare value or paying an appropriate price for healthcare and not paying for low value or waste, the two interventions we're going to talk about today are paying providers differently and addressing something called the social determinants of health. Next slide, please. So paying providers differently. One more click. Most providers, historically and even today, are paid using something called fee-for-service. They provide a service. Maybe it's a lab test, maybe it's an office visit, maybe it's an MRI, maybe it's a chemotherapy session, and they get paid for that service. And if you provide more services, you get paid more. and it's still the way, historically the way we've paid for healthcare, and it's very common today. But as part of trying to get to this system that features more healthcare value, one of the things that's going on is that smart people are looking at a lot of new ways to pay healthcare providers. The next slide. So there's a whole bunch of jargon I'm about to give you, but these new alternative methods bring in one or of these two ideas, or both. We can increase the bundle of services we pay for, or we can put more aspects of the care at risk. And I'm going to explain what I mean by that. So first click, please. So fee-for-service is our reference point. Again, you get paid for every service you provide, and nothing about the care outcome is at risk. You're not at risk for if you get a good quality outcome or a low quality outcome. You're not at risk for utilization, nothing. One click. So one of the early things that people have said is, well, let's place care into bundles. So for example, let's look at all the services needed for a knee replacement. We'll call that a bundle of care. And that way, providers now have an incentive to not provide too many services. That's a form of waste we're tamping down on. A couple more clicks here, please. You can also have something called condition-specific bundles, or even something called partial capitation. And these are all just thinking about getting to specifying bundles in different ways. Like a condition-specific bundle would be to say to a group of providers, let's provide all the care for diabetic patients for a year. And as you'll see, this form of payment is also going up the vertical axis. What we're doing is we're reducing the incentive to provide too many services, an incentive that people think exists with fee-for-service. Next click, please. You can also, the extreme end of bundling is something called capitation, where you make a provider, you give them a single payment, and that is all services for all patients in a year. And this is very common, for example, in health maintenance organizations like Kaiser Permanente or something called managed care. But not all providers are well set up to do capitation. You have to have skills that have to do with managing the health risk of your population. But we're not done. We still really haven't put quality at risk in terms of the outcomes that these providers are producing. One click. Another approach that is becoming less common is to share savings. If you deliver your care in a very cost-efficient way, we're going to let the providers keep some of the savings. But still, quality is not at risk. Another click, please. So there are other provider payment methods that say, we're going to pay you differently depending on what kind of a health outcome we got. So for example, this is actually consistent still with fee-for-service. You could give them an add-on payment if nobody is readmitted to the hospital, let's say, and once they're discharged, because that's considered a better quality outcome. Next click. You can also do something called pay for performance or value-based purchasing, which is where their payment is both bundled. Now a bundle is more tightly tied with quality outcomes, and the payment they get is going to vary depending on what kind of an outcome they got to. I think there's one more click in this slide. And then there's something called total cost of care. This is again where you're providing, your bundle is actually all the care for the patient population for the year, but now there's a quality dimension, and it's going to vary depending on that outcome. The next slide, please. So that was a lot of information on how to pay providers differently. I'm going to do a quick recap. So bundled payments is of great interest. It's a fixed payment for a condition or an episode. The good part of a bundled payment is it reduces the incentive for providers to provide too many services. But there are concerns that providers might skimp on services. And that's why with bundled payments, people like to bring in outcome metrics so they know we still got to a good outcome and they didn't under-provide services. Next slide. Value-based purchasing, that's exactly what it does. We've got a bundle, but we are also looking at the outcome before we finalize your payment. And payers approach this in a couple ways. Sometimes if providers are just getting started with this payment method, they might reward them simply for reporting on their outcomes. But as they become more sophisticated, now they actually have to meet quality targets. So while this seems to have all the incentives lined up the right way, there actually is a concern that patient advocates have, which is this type of payment model might incent providers to avoid complex patients. And if you deal with vulnerable populations, they are often complex patients. Under this payment method, providers want to get to good outcomes, and one way to do that is only to treat the healthiest of your patient population, not that they think that way. Next slide, please. There are also things called patient-centered medical homes and accountable care organizations, and this is kind of payment reform plus. Not only are we trying to create incentives for providers to do the right thing, but we've asked them to integrate with each other so that care is better coordinated. So these go beyond just payment reform. This is actually rebuilding what a group of providers look like and how they work together. The next slide, please. The big difference here is a patient-centered medical home, PCMH, is really sticking with the realm of primary care, whereas an ACO brings in secondary services like hospital services. So now you've bundled together you're hopefully not only coordinating across the primary care realm, but you're also bringing in those secondary services for even more coordination. Now, these sound like very good ideas, and there's a lot of interest in them, but the results from evaluating these types of programs is actually mixed, and it has a lot to do with providers' readiness to be in entities like this. So it's not a slam dunk, but it's definitely the way the world is moving. The next slide, please. And then just to make things completely confusing, there are some smart people out there who say, we're barking up the wrong tree with all this complex ways of paying providers. What we really need is for them to be incentive neutral, like, for example, by paying them salaries, because providers, they want to do well by patients. You know, we should actually just get out of the way. This is interesting too. So I'm afraid the bottom line is that we're still trying to figure all this out. We don't have that silver bullet that is going to get us to better health care value via provider payment. All right, we're in the home stretch here. The next slide, please. Something that is, whereas these provider payment methods are, the evidence is mixed. We're still trying to figure out how to do them so they result in only good outcomes for patients and not mixed. Something that is extremely promising is something called social determinants of health. And what people are realizing is that when we want to get to good outcomes, particularly for complex patients, we need to think outside the clinic and the hospital. The next slide, please. And this is where housing is going to come in. There's been some fascinating work that says, guess what? Only 20% of your health outcome is actually determined by your access to and the quality of the health care you received. Only 20%. I mean, wow. The other 80% are environmental factors. Where do you live? Where do you play? What kind of employer do you have? What are the stresses on your life? What are your personal health behaviors? The built environment. Do you have sidewalks? Are you in a food desert? These types of things have enormous impacts on our health outcomes. And we need to start, if we're going to get to better healthcare value or better outcomes, we need to start looking past the clinic and the hospital. The next slide, please. In the United States, you may have already be familiar with the fact that we pay way more for healthcare per person than any other country. Those are the blue bars. But it turns out we underspend on social care compared to other countries. And so something that a lot of smart people are looking at is maybe we should be changing that proportion. Maybe more spending on social care, social services, would get us to better health outcomes, and we could actually spend less on health care. That sounds promising, doesn't it? Next slide, please. Not every patient, but there are some very expensive patients out there. We're spending a lot of money on them, and they often have not only unmet medical needs, but they have unmet social needs. And these are things like somebody with severe hypertension and kidney disease Perhaps they take a medication that needs to be refrigerated, but because of circumstances in their life that their doctors don't realize, maybe their electricity has been disconnected, they don't have air conditioning, they don't have a refrigerator, maybe they're homeless and they don't have a refrigerator, and so they can't comply with what the regime that their doctor has given them, even if their medications are free. You know, there are other factors at play here. There are people who spend a lot of time in the hospital because they can't get a meal at home. They can't get some low-cost services that would enable them to take care of the healthcare condition at home. There are a host of things going on when people have unmet social needs. And the next slide, please. And what this means, actually, I'll go to the next, well, I'll stay there, sorry, stay there. And what this all adds up to is there are some really promising models out there whereby if we meet the unmet social needs of these expensive, complex patients, we're actually saving money at the end of the day. And this is where housing is going to fit in. But you do have to be very data-driven. You've got to have a very good handle on, you have to target these interventions, these social services interventions, very carefully to the patient population. Otherwise, it actually ends up costing you more than before, and you might not get it to better outcomes. And the next slide, too, please. There is a tool that helps us target. It's one of a whole host of tools, but I was specifically asked to mention it. Nonprofit hospitals get tax relief, both state and federal tax relief, because they're nonprofit. In exchange, they're supposed to provide something called a community benefit. And with the passage of the Affordable Care Act, the nature of that community benefit changed. One click, please. Under the old method, they still had this benefit, but they typically met it wasn't terribly well reported, and they typically met the benefit by providing charity or discounted care, and they may have taken credit for participating in Medicaid, our program for low-income families, claiming that we're not being fully reimbursed, so that's our charity care obligation. Under the Affordable Care Act, next slide, they have a much more robust requirement, and they are actually supposed to go into the community and do an assessment of what the health needs of the community is. Moreover, they are supposed to involve the community in this process. The next slide, please. We have a little issue brief. There's a whole host of resources that the Neighborhood Networks folks have provided for participants today. But this is an opportunity for you to leverage this community benefit obligation of the local hospitals to get to first of all, provide input into their assessment, but also leverage their findings to find the patients that might benefit from these social medical models that help meet both unmet social and medical needs. Next slide, please. So let's wrap this up. So as I've mentioned, this is a really promising model, especially when it's well targeted. The next slide. There are a lot of unmet needs. One click, please. But we're going to focus, not surprisingly, for my last few slides on housing supports. That is one type of unmet social need. Next slide. There's a lot of linkages between housing and health that are probably already very obvious to everybody on the call today. When you have quality housing, when the housing is safe, it's well ventilated, it's free from pests and contaminants, you directly improve health outcomes. That is probably completely self-evident. But there are other dimensions. When housing is affordable, it frees up money for other basic necessities such as food, utilities, and medical care. And as we all know, we need to enable families to purchase all the basic necessities. We don't want to force trade-offs between medical care and food, or housing and utilities, etc. That does not result in good health outcomes. But finally, location also matters. You already saw me refer to the built environment. Environmental cues have a profound effect on people's health. It's not the only thing, but it's really important. So housing location affects your health. The next slide, please. There have been really interesting studies. I'm only showing you one here, which shows If you're talking about a very high-cost group, and again, these interventions have to be highly targeted, you can help them with their housing by providing housing support and actually save money because your healthcare savings are so great. Don't forget, some of these people could be $500,000 a year people with respect to their medical costs, so there's a lot of room for savings. The next slide, please. But we often don't make these investments because of the return on investment. And one critical reason is there are financing silos. There's, if the savings accrue in the future, it may be hard to find somebody to pay for them now. It's often difficult to get private payers, for example, to pay for these interventions because that enrollee might not be with them in a couple years when they're getting to the better health outcomes and the health savings are being realized. So there's a host of financing options, which is going to be the subject of your next webinar that people are looking at. They have to do with, first of all, simply making sure that both housing, and social service, and medical service organizations all know the range of services that are available and become familiar with which this patient segmentation with respect to who needs access to what services. So there's just better leveraging what we already have. There is maximizing latitude within the financing silo. For example, Medicaid cannot pay room and board type of expenses. They're prohibited by law. But there's a whole bunch of support services that Medicaid can pay for. There's transportation services. There's a lot of things, and there are New York State, for example, has a model whereby they maximize what Medicaid can pay for, and that frees up money to do the direct provision of room and board type of payments. There are also waivers that states are looking at. There are something called accountable health communities, and there are pilot projects going on around the country. I actually want to wrap up and get to questions, so I don't want to go too deep into these models. That's going to be the subject of the next webinar. So the next slide, and Sarah, if you would, and there are lots of resources available. I think let's get to questions, and because I know that we'll follow up by email with respect to all those resources. And I'm going to turn it back over to you, Sarah, to moderate.
Great, thank you so much, Lynn, that was amazing. So we have 5 questions right now. I'm going to start in order of receipt. If other folks have questions, don't feel shy about writing them in the Q&A box, and if you're having any problems with the Q&A box, please just email them to health@nw.org. The first question is the tax expenditure that you mentioned early in your presentation the piece that allows you to deduct the cost of your payments to a health plan on your taxes?
Oh, good question. So that is a tax expenditure. It's actually really minor in the scheme of things. Currently, I think that your unreimbursed medical expenses have to be something like 10% of your income or more in order to deduct them. And for most families, they can't meet that threshold. I was referring to the fact that health insurance, which is, employers might spend between $10,000 and $20,000 per employee, depending on the extent of family coverage on health insurance. That's an enormous source of compensation, and that compensation is not subject to income tax. And what economists would call that a tax expenditure. And in fact, one of the levers that policymakers look like is capping the amount of health insurance that is excluded from income tax as a way of putting some downward pressure on prices. Now, not everybody likes that approach. So this tax expenditure is enormous, but it refers to the fact that what your employer is paying on your behalf for health insurance is not subject to income tax.
Great. Can you talk a little bit about who pays the health costs of uninsured?
Sure. So, there are a number of folks who pay the health care costs of the uninsured. So the uninsured themselves pay what they can. They also go without, so they pay a cost in terms of poor health outcomes, and there's some pretty awful stories out there about people who didn't get the health care that they needed due to concerns about cost and suffered terribly or even died. Healthcare providers will provide reduced cost or free care, depending on the provider, but not all of them. There are also federally funded clinics who, by their design, are designed to be safety net clinics that are available to these populations, but they don't exist in every entity. All hospitals with emergency rooms have a legal obligation to stabilize any patient, regardless of their ability to pay, if they walk into the emergency room. That doesn't mean that they're getting all the care they need, but they're getting the care they need in order to be stabilized. And many hospitals will say that they then jack up their rates to other types of payers in order to, cover the unmet costs of those types of patients. Now, there is a lot of debate about whether, or that's called cost shifting, and there's actually not complete agreement on whether that is a real phenomenon. I won't get into the economist's angles on that question, but that sort of lays out for you all the different ways in which their care is getting paid for when they even go to get care.
Great. Who are these people? Who are the people who help seniors with making decisions about selecting a Medigap plan or Medicare Advantage, selecting which plan is right for them?
So there are a lot of folks out there, but one of the most common is called a SHIP, S-H-I-P, and that's State Health. I forget. I'll have to we'll have to email it back to you. But these are sort of consumer navigator type of entities. They're staffed by volunteers, and they have proved vital in terms of helping seniors navigate their health insurance choices. Seniors also often turn to their children. I can't tell you how many stories I hear about where it's my peer has come to me because their parent wanted help and they weren't able to help the parent. Some of these seniors just face an overwhelming number of choices. There are also, they're not often utilized, but there are some pretty good online tools that help seniors navigate their choices. But the SHIPs are some of the best ones that I think have really figured out how to do this and how to provide the information to seniors in a format and at a level that's just right for them.
SHIP stands for State Health Insurance Assistance Program. I guess they didn't want to do SHIAP. So let's see. We have a lot of questions. I think we can get through them all. Okay, here's one that could have a long answer, and I'm happy to add a few if you'd like me to, Lynn. Can you tell us about some of the innovations you know in housing that hospitals have promoted or supported? Do you want me to give you?
No, please do.
Okay, so I'll discuss a few, and some of the folks in the audience might be parts of them. Well, there's a good number of hospital partnerships around home rehab, especially in two situations. One is a broad-based support of home repair after someone's being released from the hospital, and they could have multiple different types of situations. It could be COPD, other respiratory health issues like asthma, or it could be sort of mobility concerns. And there's a couple of examples of that in the NAWORCS network that I can point you to. NECAC is involved in one down a little bit further south from where I'm sitting right now, although I guess not everybody's in the same place as I am. NAWORCS Western Vermont also has an example of a hospital partnership around home repair. And there's a few other examples in that, or there's a bunch of other examples in that space. And some of them sort of do focus more on the elderly or folks who have issues with physical limitations. And some Medicaids are moving towards incorporating that into their waivers. So Michigan, for example, I believe is moving towards supporting integrating some level of home repair, in association with occupational therapy and a bunch of other home-based interventions. But there's a lot of different examples in that space across the country. Another set of examples that I'd give you would be in California. Let's move from Vermont to California across the country. And recently, a variety of hospitals and insurance providers got together to invest about $22 million in housing. Some of it is for, the new word is familiar faces, the folks that Lynn was talking about who go to the emergency department frequently, but there's a broader range of work there, and that did include hospitals. I could really go on for a while with many more examples, and we're going to dig deeper into that in the next webinar. We just wanted to sort of, this webinar is mostly designed to give a sense of the different ways that health providers and payers are moving towards outcomes, which would shift towards that type of partnership model. So here's another question. Oh, well, and I can give another example. There's also a cohort of 11 national projects ongoing with the Green and Healthy Homes Initiative that seeks to address the environmental causes and triggers of asthma using value-based purchasing to improve housing conditions. And the nice thing about this example is not only is it an amazing example, but it is also, we have some NeighborWorks network organizations involved in that. The one that comes to mind is Home Headquarters in New York, but there's a few others, so I apologize because I'm trying to go quickly. Yes, definitely you'll hear of other models on the next webinar. And we have a question saying, how can I find out if my local hospital or other provider system is part of an ACO or accountable care organization? Or in Oregon, I think they call them CCOs. Lynn, I'm going to turn that one over to you.
Well, it would not be easy to do so. It's usually invisible to the patient. And in Oregon, I'm very impressed you know about their CCOs, and that is just FYI within the Medicaid payer tranche. I don't think it refers to non-Medicaid ACOs. So bottom line is you probably wouldn't know that you were in one, and they also, there isn't like a single ACO model. There are kind of loosely integrated ACOs. There's tightly integrated ACOs. So, you know, you would have to kind of be up on, you know, the wonky state health payer news type of thing to know which ones were ACOs. I'm sure that's not a very satisfactory answer.
Yeah, we have unleashed a volume of questions, which is good. One question was, is bundling really possible given the unique natures of each person's medical condition? And actually, before I let you answer that question, I just realized we are coming up on the end of the hour. I'm gonna, we'll try to answer that question via email or some other way. And I'm gonna turn this over to Hugh, who's gonna wrap it up and talk about the next webinar. And also, you may know, you may notice in your chat box, please evaluate us here. You can start evaluating us before we even have finished up. Hugh.
Thank you so much, Sarah, and thank you, Lynn, for this great presentation, and thank you all for joining us on this call. Because we're getting close to end, I'll quickly go through this. We do have a tools and resources folder that we set up for all of you attending this webinar. It is available, we set up a Google Drive folder, and we will be sending you the link along with the recording of this webinar and another opportunity to fill out our evaluation survey. Please do give us feedback on this session. It'll help us as we develop more webinars, particularly the second part of this particular webinar that will be coming up in May. We will also, just to make things a little easier, we'll also be pushing out the first question of the evaluation as a poll question shortly. So the next webinar, so part 2 of this series will be taking place approximately exactly 1 month from now, and we'll focus on partnerships related to healthcare financing. We will have Alicia Saunders from Leading Age to discuss health and housing partnerships to support community residents as they grow older, and David Zuckerman from the Democracy Collaborative to talk about partnerships with hospitals. Lynn will be joining us again, if you can join us in this part 2, and she's generously agreed to join us again to give basically a 5-minute synopsis of what you've heard today. So please feel free to share this upcoming webinar with any of your colleagues who may not have been able to join us today. Again, this will be on 4 weeks from now exactly, same time. Registration is required once again, and on the follow-up email that you'll be receiving in the next couple of days, we will have a link to the registration for the next webinar. Anyway, thank you all so much for your time. I'm going to push out this poll question now. If you would deeply appreciate any feedback that you can provide, and if you have any questions or any additional feedback that you don't want to share with us via our survey, please do feel free to email us at health@neighborworks.org.
And while you're filling out the poll, I saw somebody ask a question, which I can answer in 1 minute, which is, yes, this will be recorded. And if you registered to it, you're going to get all this information, including the recording, and you can share it far and wide. So with that, it's 2 o'clock. Have a wonderful rest of your day for the West Coast people. We still haven't finished morning. So I was going to say good afternoon, but good day, everybody. Thank you. Bye-bye.